Well, welcome everybody. I'm so happy to see everybody here. We're here for today's session on breast cancer awareness, and it's been organized by our EFED medical team. For those of you who don't know me, I'm Kelly Feenan. I'm an EFED staff member, and I'm moderating today's event. So it's great to see everybody here that's present in the Italian room. We also have people streaming from all over the globe, from EFED, WFP, and FAO. So welcome to everybody, whether virtually or here present. So this is actually really a global event, which is really cool. So we're also really pleased to have some special guests with us today. We have the president from Oncology for Africa, and that's Ms. Titi Andreini. Where are you? Oh, where'd she go? Okay, there you are. Hi. Okay. Okay. And then we also have Ms. Claudia Sciarra, who's a representative from the Susan G. Komen Foundation. He's with us here today. They've brought us all kinds of materials that over there on the table there, if you want to take a look after the session. They're also here. They'll be available if you have questions and you want to during the session or after the session. Okay, so please feel free to take advantage of their knowledge. Okay, so thank you everybody for joining us today, and we're really glad that you're here. So the medical unit has put together a really fantastic, informative session that's kind of just packed with information, and I'm really eager to get started. So during today's session, we're going to have a presentation from our medical advisor, Dr. Hayford Ete, and we also have two prominent Rome-based oncologists with us who are here to talk about breast cancer treatment and prevention. We have Dottoressa Antonella Savarese. I'm just hoping that I'm doing this. The Italian is like, okay, I know I'm going to stumble at some point. But she's an oncologist at the Istituto Nazionale Tumori Regina Elena, or IFO. Okay, and then we also have Dr. Lucio Fortunato, who's an oncologist surgeon, and he is the clinical director for Senology Center at San Giovanni Addolorata Hospital in Rome. Okay, I got it. Okay, yay. We're also going to have a beloved former colleague to talk to us about her personal journey with breast cancer. So we'll see Carletta a little bit. Yay! And after the presentations, there'll be plenty of time for you to ask questions, which is great. So really, today is about having an open conversation about breast cancer prevention and also an opportunity to ask the experts questions. Excuse me. So I'm sure that today's session is going to be both informative and also inspiring. Okay. So to get started, I would like to ask first Chitra Deshpande to join us to do a little introduction. Chitra has a very long career at EFAD and also at FAO, and she's also been the helmsperson. She's been the helmsperson and founding member of the Women's Informal Network. And this is it started a very small network, and now it's a global network that is with chapters in Rome, Geneva, Nairobi, and New York. You know, I read an article today in Forbes magazine which says that women who support women are more successful. Okay, and they have a great tagline in the article. There's power in the pack. Okay, so I think that's really cool. WIN has been extremely supportive in promoting this event, and we're very grateful for Chitra to open this up for us. Thank you.
So thank you again, Kelly, for that great introduction. And good afternoon, dear colleagues. I'm really pleased to see all of you here, and even those in FAO whom I cannot see, and WFP and globally. It is truly an honor for me to be here today and join Dr. Ete, Dr. Fortunato, Dr. Savarese, and our dear colleague, Carla De Donato, to join them in this important discussion on breast cancer prevention. While many of you know me from my days in OPV, or perhaps as in my current position as Senior Evaluation Officer in the Independent Office of Evaluation, I happen to also be a doctor. I earned my doctorate examining the lives of women and how women in India in particular, and how they empowered themselves through political activism. From this interest and commitment in gender equality and women's empowerment, I founded, with a handful of EFAD colleagues, the Women's Informal Network in 2016. Today, as already mentioned by Kelly, we have over 550 members globally, with many chapters in New York, Geneva, Rome, Nairobi, and a new one starting in Vienna. But WIN is an informal professional network of women working in international development. Our objective is to promote inspirational women's leadership. We focus on women's career development, work-life balance, and leadership. However, WIN is not only about supporting women in their professional career progression. We also care about their health and well-being. That is why I am here today, because of WIN and my own personal commitment to the well-being of all women. As women, we are the pillars of our families. So if we are diagnosed with cancer, our whole family is impacted. And breast cancer is the most commonly diagnosed cancer in women globally. Fortunately, medical advancement has made it possible for good screening, early detection, and a chance to be cured. It is also true that those affected are getting better care than in the past. However, the outcome of breast cancer treatment largely depends on the timing of detection. Health promotion interventions make an immense contribution to early detection and improved survival. My mother-in-law was able to detect her breast cancer right away through a self-examination. Her sister was not as lucky. As professional women, we often find ourselves too busy with work and family responsibilities to take care of ourselves. We sometimes forget to do self-examinations, or perhaps we were never taught how. Those of us in Rome may also forget to schedule our free annual mammograms at Santo Volto. Or we may be confused about the latest research on when we should start doing them. Today, we are here to have an open talk about breast cancer prevention and ask the experts all our unanswered questions. We hope that by talking about breast cancer, we can all be reminded of why prevention and screening are so important and spread the word. So I congratulate each of you for coming here today. You have taken the first step towards breast cancer prevention for yourselves, your family, your friends, and your colleagues. And please join WIN in rallying fully behind IFAD's Medical Service Unit in further advancing the course of breast cancer prevention in this year's Race for the Cure on May 19th. Today, as Kelly already mentioned, we have colleagues from Komen, which organizes the Race for the Cure, as well as the president and founder, I understand, of AFRON. AFRON is another committed organization that implements cancer prevention and control programs in Africa. In particular, they provide for women in Uganda free cervical and breast cancer screenings. In rallying behind all of their efforts, we are not only supporting prevention, but also supporting all the women who survive, encouraging them to stay positive and to continue to hope for a cure. Thank you.
Thank you so much, Chitra. And we really, really appreciate all the support from both you and WIN. I believe that your point about how we women often find ourselves too busy with work and responsibility to take care of ourselves is really spot on. I sometimes think that as women, we're told that you can have it all. But actually, I think that's a trick. I think it's a trick to get us to do it all. Okay? Okay? But on a more serious note, I think too often we don't put ourselves first. And putting our needs, especially our health needs, at first, putting those on the back burner can really have disastrous consequences. So I think that one of the take-home messages from the takeaway points is that self-care is very, very important. So that's for the first take-home message for the day. Now, I'd like to turn my mic over to a former colleague who I'm sure is known to many of you. Carla De Donato, or Carletta, has kindly, and I think quite bravely, agreed to share her personal story on her battle with cancer with us. She's a well-known advocate for breast cancer awareness and is a great support to other women who are going through the same problem, the same battle. She's here today to talk about her personal experience as well as the organizations that she works with to help women. Okay, so Carletta.
Good afternoon. Thank you very much, Kelly. Thank you for inviting me to this interesting seminar. Thank you very much to the medical unit and to our special invitees today. I'm going to tell you a little bit of my personal history with breast cancer. I started in 2003 when I was only 39 years old. I was diagnosed with carcinoma, breast cancer, a very aggressive one. And immediately I had to be operated, and I was undergoing mastectomy with many lymph nodes which were positive. So my oncologist, who is a very, very good one, Dr. Estafabi, who is in the Regina Elena Hospital, followed me, and immediately we had to, she prescribed me with a very aggressive chemotherapy. And after that, radiotherapy was followed, many cycles, and obviously as well the combination of the hormonal therapy. After this, I went also followed by many checkups and screening and follow-up during many years, and the hormonal therapy especially lasted 10 years because of the aggressive kind of carcinoma that I had. And this is because obviously they wanted to prevent recurrence of the tumor. Unfortunately, on the 10th year, I was already having a champagne when another breast cancer cell, exactly the same one as many years before, appeared as a 6 centimeters visitor in one of my ribs. So again, I had to start all over again. Exactly the same chemotherapy that I did many years before, and then combined by a biological therapy, which is called Herceptin, for my case. And with this, it's been already almost 4 years now that I've been going through this biological therapy every 21 days. And I think that this is going to be for quite a long time. This shows that research has gone so far, because in 2003, we would not imagine that a new biological therapy would go and attack this kind of cells that I have, whereas in few years' time, research is done a lot. So this is helping me as other women to fight against breast cancer again, wherever it comes as a metastasis. What did I think during all these years was that I did not want to be passive, but I wanted to be active. And telling other women that awareness is the first thing, self-examination, as what Chitra was saying, is very important, and prevention. We cannot say that we live in a country where we are not taken care of. We have many institutions, many hospitals, many private doctors who can inform women and can inform families and can inform everyone about breast cancer and what to do and how to prevent it. So I was by chance introduced to Giusy Giambertone, who is a wonderful woman who is attending today's seminar. She is on her way. Together with Dr. Lucio Fortunato, they are part of the board of directors of a wonderful foundation which is called Prometheus. And they are specialized in creating symposiums and congresses and conferences specialized on breast cancer. And please correct me if I'm wrong, Dr. Fortunato. And they take very much the wellness of women. Not only that, but they do so many other things, like we have participated in makeup courses. They have invited us to gala dinners, and they have asked us volunteers to dance in front of many people, as last year, to show that we can do it. It doesn't matter about the breast cancer, but we are fighting also through this kind of show. And they also do many other things for professional nurses, fellowships. They also train doctors in Italy and abroad. And this was my first impact with another world, which was not only chemotherapy, hormonal therapy, or radiotherapy, or being just a patient. I was active. And after that, in 2015, I was at the hospital at IFO, and I met a wonderful team of women who, some of them are present today with this uniform, who are called the Pagalle Rosa Pink Butterfly Team. We are an association of women, all BCS, breast cancer survivors, who do a very weird sport. We paddle a big dragon boat in the Lake Albano of Castel Gandolfo. This dragon boat is a canoe of almost 13 meters, and 20 of us paddle a big paddle, and there's a drummer and a helmsman, or a helmswoman in this case. Sometimes I do the drummer, and the captain is here, Barbara, and Laura, and the other, Monica and Alessia, have been there for some years now. We not only do this as a sport, because we like it. It is really tough, I must tell you, but we do it for one special thing, which is prevent the lymphedema on the arm which has been operated. And this is very important because the movement of paddling avoids having an arm swollen. And this movement was created and invented by a physician, a Canadian physician, Dr. Don Mackenzie, who, by trying with these ladies who came to him for physiotherapy, they said that they couldn't do anything because they were operated breast cancer survivors. And he said, no way, you're going on a boat. I'm going to monitor you for 6 months, 20 of you and 20 other ladies who have not suffered from breast cancer. After 6 months, he has monitored these 2 dragon boats, and he could see that the 21 breast cancer survivors had done a team. Quality of life was super. They were really having fun, living in the open air. And the other 20, because they did not have an objective or a mission, they were just going there for paddling. So the movement in 1996 was taking place, and now we are 4,000 women all over the world, 140 teams who meet every 4 years for a festival, like we did in July last year in Florence, and many other years in Australia, in the States, in New Zealand, and other countries. We're waiting for the next festival, we don't know where. And it's now a worldwide festival and movement, which is very important. So this is my personal story from the breast cancer to what I'm doing today, which I don't think about that. It's just trying to be active, trying to help other women, engaging other women, recruiting other women or other men, because in Florence we had 2 men, actually. out of 4,000 women. The percentage is very low, but still there are, unfortunately. So this is my story. I hope you can bring this to other friends, other women, colleagues, as Chitra was saying, family members and friends. And I would like to ask you, please add prevention into your to-do list. Your shopping list should always have prevention as first item. Thank you very much.
Thank you. Thank you. That was really inspiring. You know, I think the message here is you've got to be as aggressive as the cancer, right? You know, you've got to be just as aggressive, you know, and it's amazing. And it also brings to mind the power of the pack, you know, so women supporting women is just awesome. Okay, so before we turn to our panel discussion with our guest doctors, I'd first like to turn to the IFAD Medical Unit and our medical advisor, Dr. Hayford Ate, sorry, God. Dr. Ate recently joined IFAD, and so for the first time we have our own dedicated physician on the IFAD premises. So Dr. Ate is going to be talking to about the IFAD prevention program, and at the end of his presentation, we'll have some time for questions, okay?
Thank you very much, Kelly. Thank you very much, everyone. Good afternoon. In fact, my session is just a brief overview of what IFAD Medical Service is doing with respect to breast cancer prevention. And the subject really under discussion is one that is considered very important by IFAD Medical Service and is one of the main drivers of our health promotion program. When it comes to cancer prevention, the RBA Health Services actually have adopted a common approach where the cancers we focused on are one, breast cancer, and we recommend that screening is started from age 40. And the main element options of screening include expert examination, mammography or mammograms, and then ultrasonography. So from age 40, we recommend that you start an appointment with your expert to get an examination and a recommendation made. The second cancer we focus on is cervical cancer, again for women, where we recommend that from age 21, you begin the screening with your experts. We also focus on colorectal cancer for both men and women, where from age 50 years, we recommend that you start screening. And finally, we also look at, for men alone, prostate cancer, where again, age 50, we do the PSA, the prostate-specific antigen from the medical service using the BIOS lab. Now, we also recommend for women to see your gynecologist for full examination, taking into consideration the other organs of the reproductive system, looking after the ovaries, the womb itself, the fallopian tube, etc., to ensure that, you know, they are all kept healthy as a comprehensive women wellness program. On breast cancer prevention, as I've stated, our recommendation is to start from 40 years. Unless after you've met your doctor, there are specific risk factors which probably categorize you as a high-risk patient, for which they may recommend a different frequencies and timing of starting of the screening. We have an agreement with Santo Volto where if you're a staff member, you can go there and have your screening done, and it's 100% coverage. Consultants and short-term staff could avail themselves also for same screening, which they would have to pay and later on get 80% reimbursement from their insurance. And to do this, you need to see us at a medical service, make an appointment with the IFAD nurse, Kim Harvey and Edgardo Scano, get a referral note, make an appointment with a hospital and get a screening done. If you need any further assistance on that, please do not hesitate to contact us. If an employee prefers to use any other facility other than Santo Volto, yes, you are welcome to do so. However, this may require that you pay an advance payment and get 80% reimbursement from the insurance. It's well stated here at this point that some of the facilities have direct billing arrangement with the insurance, for which reason when you go there, you only do 20% co-payment. You don't do the full 100%, and the facility would send a bill to the insurance for the 80% direct. Our colleagues in the ICOs are encouraged to approach the UN medical facility, where we know that most of the UN medical facilities have arrangements for such screening programs, or the UN examining physicians in their locations. If you need any specific help to get a screening done, please, you can write an email to any of us, myself, Kim Harvey, or Edgardo Scanu, and we will assist you to get the screening that you need to do. I'll leave it here so we can have more time with our doctors who are here. Thank you very much. Thank you.
You mentioned about ICO staff. So also, if ICO staff member comes here, can they take advantage of the prevention program?
At the moment, we have some difficulties with the insurance, which I am in discussion with Pierre to see how we can resolve it. So that is on the discussion table.
Great. Okay. Okay. Are there any questions from the audience for the doctor at the moment? Okay. All right. Yeah. Great. Okay. So, yep. Here we have. Oh, yeah. Yeah.
The lady that had cancer before, just talking about rowing to help detoxify the lymph nodes in the arm, you know, that have been removed. But from what I understand, they don't do that anymore. They don't remove the lymph nodes because the lymph nodes are actually your immune system. So it's obvious there's going to be cancer cells in there. But I don't think they do that anymore. Is there a surgeon here?
Okay, you know,
Are you a doctor? Do they do that? Still remove the lymph nodes?
Yeah, you know what? Well, that's a great question.
Yeah.
And we have our two oncologists here who are here to answer that exact question.
Okay, right. And are you actually also going to talk about? You're saying screening, but once you found the cancer in your breast, could it be either calcification or whatever it is? Don't you think that's too late? It's like you should think well before, you know, to understand why cancer gets into the body and how you can prevent it that way. Because once you've had the screen, you find a dot of calcification, then it's too late. You know, your whole body is involved in cancer, not just the tumor in your breast or wherever it could be.
Excellent.
You know, so you are going to speak about that as well.
Okay, I think the doctors will be addressing that
Yes,
as well.
yes,
Okay,
exactly.
That's perfect. It's a perfect segue. Thank you very much. So, yeah, tell me.
Hello? Okay, great. This is very specific for Dr. Ete, just to ask, and confirm, the wives of our colleagues are also eligible for getting the screening at Santo Volto? Yeah.
Yes, yes.
Great, that's a great question. Okay, yeah, okay. Good, okay. So,
Just a suggestion for women that go to Santo Volto. Sometimes they do something like self-made. So they go for mammography and okay, it's good. I don't take a following visit to the doctor. Please show the mammogram to doctor after the examination.
Well done. Excellent.
So it's not automatically, but we need just to check very well the breast, the X-ray examination, and the visit after. So.
Excellent, thank you. Okay, all right. Well, actually, this is perfect. It's perfect timing. Now we're going to start our main event of the day, which is the panel discussion with our two expert doctors. So our first guest speaker today is an oncologist at the Istituto Nazionale Tumori, Regina Elena Ifo, and she's Dr. Savarese, and she'll be speaking to us about treatment options for breast cancer. Following the presentation, we'll have time for questions. Okay.
Thank you very much for presentation. I'm honored to be here. I'm a medical oncologist, so this means that I treat cancer, in particular female cancer, breast and gynecological cancer. And I'm also involved in prevention for hereditary cancer. And, but I'm also involved, as you can see, in IFRON. So I'm founders of this association that works for promote the breast cancer and cervical cancer screening in Uganda. Okay. As first, what is cancer? Just 2 words. Cancer is an uncontrolled growth of cells, of normal cells that became abnormal under several several external heat that came from environment or our lifestyle and so on. This cell lose the capability to die and became like immortal, and they are capable to grow, to produce a new growth of vessels, and the new vessels, new blood vessel means that new oxygen, new nutrients go to the cells, and the tumor can grow, and this is at this time it is impossible for our body to control following the normal pathway of our self-control, this uncontrolled growth. The global incidence on cancer is scary. We have more than 18 million of new cases per year, and mostly these are distributed. They are distributed in Americas and Europe, but we can also see in Asia, and it's less frequent in Africa. But in Africa, we don't have cancer registries enough. The top 5 are lung, breast, colorectal, prostate, and stomach. These are called the big 5, because they are the most frequent cancer in the world. But as you can see the population that very often became sick of cancer is rich population, so the North America, Australia, and Europe. But the mortality in these countries is much lower than incidence. So in these rich countries, we have a lot of cancer, and we cure very, very well this cancer, so people survive. In the less rich countries, in poor countries, incidence is lower, but the mortality is more or less the same. This is a big disparity in the world. Why we can develop cancer? For a lot of reasons, especially for insane lifestyle, but also for medical treatment, for gender and familiar risk factor, and also for infection. Don't forget this. Breast cancer, we are finally here. It's not a new disease, breast cancer. This is a miniature, Italian miniature of some centuries ago, these doctors are trying to cure, to operate these poor women. So the breast cancer exists since many time. But now we have much more cases in the world, as you can see, mostly in richer countries. The origin of cancer is the duct, the breast duct, the same duct that produce milk in breastfeeding. So ductal in situ is a cancer very limited. Infiltrating tumor is the mostly tumor that we observe. Causes and risk factor of breast cancer. We don't have just one reason. We don't have just one risk factor or one causes. There is a mix of these factors. Gene mutation from environment or for familial reason. Late childbearing, early menstruation, so something that happen in our personal history, but also the prolonged, too long use of hormone replacement after menopause, and insane, as you say, insane lifestyle, so too much alcohol, too much fat food, too much smoke. This is one special risk factor. This is the scheme of a typical family with inherited breast cancer risk factor. You see there is an arrow there. This is a woman that has cancer, breast cancer. Her daughter too, her mother too, and the aunt too. And also the cancer was also in the daughter of the aunt of the grandmother. This is a clear family in which we have to think that something inherited happen. So if you have in your family 3 or more breast cancer, ovarian cancer, male breast cancer, or cancer that appears as early onset before 37, or bilateral breast cancer in family, please think that probably you can have inherited breast cancer risk. What we can do to prevent cancer? Primary prevention is the optimal, because we can avoid that cancer develop. Education, vaccination, not for breast cancer, but for cervical cancer, for instance, lifestyle modification. But we have also secondary prevention that is made by screening, early diagnosis tool, or treatment. The treatment means also cure the cancer and works for the prevention of a secondary cancer. Modify lifestyle. Please avoid smoking. Please reduce fats and alcohol. The reduce fats means also reduce meat, reduce salsiccia or salame, reduce patatina. Eat fruits and vegetables. So these are food with high concentration of antioxidants agents. Do physical exercise, a lot of physical exercise, as Paglia Rosa say. Do not, it's very hard, but do not exceed in hormones implementation for menopausal status. So we can do this, but no more than 5 years after the menopause. Cause later is not so proven, is not so sure, but probably is dangerous. And take care of personal hygiene. So all this is personal hygiene. The color of food, you know, blue, purple, bulb pulp, red, yellow, green, and white. In the case in the inherited cancer, there is another private option for primary prevention, that is the surgical prevention. I think you know that Angelina Jolie chose this option, removing ovarian and breast cause the inherited risk to have a breast ovarian cancer. So in this family, to do a prophylactic surgery can really reduce the risk to develop cancer, as in this case is the survival is for ovarian remotion, and prolong the life of these people. But also if a woman experiences breast cancer, if remove the contralateral cancer, and she's BRCA mutated, so she belongs to a family with inherited risk, can reach a longer survival probably. So surgical option for primary prevention could be safe for these women. Early diagnosis is the secondary prevention. So I can avoid cancer, but I can observe cancer when it's very, very at early stage. And so we can reduce also the treatment for this disease. Breast self-examination is not alternative to medical examination, but can help very strongly. So please learn to make self-breast examination. Medical examination is strongly dependent from physician experience, so please make your visit where a lot of cases are seen. So in very crowded, very big center for breast cancer prevention. These are the modality for breast self-examination. I left my slides, so if you want to see after or print this slide, you can do it. So look your breast in the mirror, standing, or also when you're lying in the bed, or also when you are under the shower. If you touch your breast very often, the minimal difference during the time can be perceived very easily. For small breast, this is more true, obviously. For big breast, perhaps it's difficult. But anyway, the difference that you can perceive are very important. The tool for early diagnosis is anyway made by radiology tools, RX mammography or ultrasound scanning. They together give a sensitivity of 60%, so not so high. But it's very important that these are made in very skilled center. Okay. In this case, it can be very, very useful to make a diagnosis in early stage. The RX mammography is not dangerous, so the radiation is very, very low now with the new machineries. And the effectiveness of the mammography depends on the size and the density of the breast, the density of the lesion, the tumor, if there is, yeah. The hormonal phase never do a mammography in the second phase of menstrual cycle, and from physician experience. So the importance of the center that do prevention. Ultrasound scanning is just for help the mammography to see better. It never used alone in screening procedure, but can help. And this is a special case when the breast is very, very dense. In young people, this often occur. We can use also magnetic resonance. You see, these are breast dense, very dense. This is the mammogram of this breast. The radiology don't see nothing, it's white. But there is something, do you see the arrow? There is something wrong. There is a very little tumor that only the magnetic resonance is able to perceive in a breast so dense. So in very young and dense and very dense breast, we can also use in special occasion magnetic resonance. Why to adhere to screening program? Because we can have a very high improvement in health, in survival, and as has been said, is a wellness for the family, for the single, for the family, for the colleague, for the friend, for everything, for everyone. In Italy, the screening have been are growing, have been launched several years ago, and now the call from our health center are much more frequent, and so we are growing in a screening program. This slide can show how it is important to do at regular time interval the screening, because it's just in repeating each year or each 2 years the screening, it is possible to maintain the benefit for an early detection of cancer. And this is the mortality. The red line is the mortality of women that adhere to screening program. As you can see, is they live much more than people that don't adhere to screening program. The screening, these are the Italian law. Under 39, no evidence that is that has a great impact for health public. Just people with BRCA mutation do cancer screening at this age. But from 40 to 49, there is an evidence that there is a benefit. So the Italian law don't consider this population. Anyway, we strongly encourage women to do mammography since 40. From 50 to 69, the national health system called women for the screening. And these categories of age, the mortality is reduced by 35%. So these are good results. After 70 years, the screening is effective, but the evidence are not so strong, and over 45, the public health closed the screening. So it depends on the family, on the family history, on the inherited risk to continue to do control. And if cancer happens, so we can do prevention, and we can find also, and we can find the tumor. This is the secondary prevention. We hope that the tumor is very little, and so we can do very, very few medical intervention. But if cancer happens, these are the breast cancer symptoms. I think Dr. Fortunato is agree with me. Don't wait the symptoms for breast cancer because they are late symptoms. But anyway, if you see an unusual increase of the size of the breast, if you see the nipples, they are different from each other, and if the skin is different, is rough, please think that something is going wrong in this breast. And the breast can also occur in men. Please don't forget, as been said, don't forget that also man is very rare. Is 1% of breast population is a man, but can occur. So say to your sons that can be during the life. This is a breast cancer, but the diagnosis of breast cancer requested 3 passages: the physical examination, the documentation by RX mammogram or ultrasound, and a needle biopsy for the sure diagnosis. These are the triad that we need for cancer diagnosis. And no, there is no arrow. And these are the stage of cancer. Stage 0, so in situ carcinoma, stage 1, are the major goal of the prevention, because the tumor is very, very small and it is very easy to cure. Stage 2 is when the tumor is localized, but small, but not so small. Stage 3 is when the tumor is advanced in the region of the breast, and stage 4 is when there is the presence of metastasis. So I mean metastasis outside axilla, metastasis in the liver, in the bones, in the lung. The treatment modalities are surgery, radiation therapy, and systematic therapy, so oral on IV therapy. This you can see much better than me later. Radiotherapy after surgery is mandatory if you receive a breast preservation. And if the involvement of the axilla is very high, we can also prescribe radiation on the region. But usually is a very short therapy, more or less 30 application, so more or less 40 days continuously. Hormonal therapy is for cancer with high level of estrogen receptor. This is the most used therapy when the cancer is a well-differentiated cancer, when the woman is an old woman, or just to maintain a cancer control after chemotherapy. Chemotherapy, I think, it's impossible to say what is chemotherapy in few words. Chemotherapy is a systemic treatment, is given IV, usually give a loss of air, sometimes nausea or vomiting. In case of complication, fever, diarrhea. Chemotherapy give fatigue, asthenia, loss of menses in premenstrual cases, or possible infertility. Chemotherapy is a mix of chemical agents that are usually given together or alone before radiotherapy and before hormonal therapy in case of adjuvant therapy. But now we have a lot of new drug. We say this target therapy. So we have a target on the cells. The target can be a receptor, can be genetic modification, can be a growth control bullet to use. We have a lot of the different agents. These are several, some of these, that can control the growth of the new vessel, that can control the growth of the cells, that can control the relationship between cells, and can stop also the dialogue, the talk inside the tumor cells. Usually are oral or intravenous drug, don't give loss of hair, but skin, heart or blood side effect. So are not completely without side effect, important side effect. And the new frontier is immunotherapy for cancer treatment. The new frontiers, why? Why now we learn how to remove the block of the immunologic system. So our body can recognize the cancer cell as a stranger with the help of this new drug, but are not completely without side effect. We can have autoimmunity side effect, very, very important. And this is important to say, because people now think that immunotherapy is completely safe because there is no loss of hair. But it's not true. It's a very, very important tool, but we have a lot of side effects possible. 10 rules for preventing breast cancer in daily activity. I can let you this. Please choose a diet based on Mediterranean principle. Perform physical activity. Abolish smoking. Avoid overweight. Don't give up the small contraceptive, but use low dose one. You can do, but be careful. After menopause, don't use all-out hormone replacement therapy for a long period. Food supplements contain a micronutrient that can be taken with a balanced diet. So the rule more supplementation is better is not valid. Ask your doctor for this. Because don't exaggerate in supplementation. If you eat well, you don't need nothing. Always reply the screening invitation. If you have a family history, please give to the doctor. If you use constantly self-examination. And that's 10 rules for prevent breast cancer with nutrition in daily, in the supermarket when you buy food, at home. Consume at least 2 servings of fruit and vegetable per day. Don't exceed in milk or derivatives. Limit consume smoke, fried food, or burned food, but barbecue is cause the meat burn, and so is insane. Limit alcohol, no more than 5-7 grams per day. Don't buy always the same product when you buy food. Change the brand. The reason is change the brand can reduce the constant intake of the substance that the manufacturer put inside the food. So several brands probably will contain several different substances. And if you rotate, you can avoid poison, but you can rotate so you can avoid the overexposition to eventual product not completely safe. Don't buy vegetable of dubious origin. I mean, if there is the suspect that the water for irrigation is not clean, I think you can think to the river, to the Tevere irrigation. It's horrible to think. At home, when cooking, don't use worn plastic containers or pans, and fry, for instance, with vegetable oil. And when you cook meat, remove the fat and don't burn it. Okay. Just one, the last one, la rete orcologica regionale. So these are our local government. It identify this breast center for each regional area. And I show you here, as just in case you want to know which are the public address for breast unit and diagnosis, cancer diagnosis. Okay, thank you.
Thank you very much. What I think I'm going to do is I'm going to ask Dr. Fortunato to speak, and then we can lift up the screens, and then we can have a question session. If that's okay for you. Thank you. Okay. Okay, so just to introduce our next guest is we have Dr. Lucio Fortunato. He's an oncologist surgeon who is the clinical director of Senology at the clinical director of the Senology Center at San Giovanni Addolorato Hospital in Rome. Okay, doctor.
Thank you. Thank you very much. Thank you all. I'm really honored to be here today. And I will give a talk about my life, what I have done as a surgeon for this fight against breast cancer. And I will share with you the advances that I am implementing every day, the new treatments for this kind of fight. I would like to introduce, though, I would like to introduce my talk, however, showing you that not all tumors are the same. We think that we have one cancer, and in fact, this is not the case. We have probably 100 different cancer, and understanding what kind of tumor I have to treat is the biggest part of my job. And in fact, this is a genetic assessment of breast cancer, and we understand that the estrogen receptor positivity, more or less, divides tumors in luminal tumors, in which estrogens are highly expressed, luminal B tumors, HER2 positive tumors, in which the growth factors are expressed, and triple negative or basal tumor, in which none of them are expressed. And each one of these type of tumors, in fact, have a different behavior. And we try to understand that to make the best assessment and understand what kind of treatment is the best. And Dr. Saresa has shown you also this picture, but I like to share again with you, because the second thing that I haven't understood, we have understood, is that not all countries in the world are equal, and that richest countries have a very high incidence of breast cancer, and Italy in Europe is among them. In my job, surgical re-excision after a first tumorectomy or wide local excision or quadrantectomy, they express the same concept, have been very, very frequent. And this is back in 2014, showing that in the United States, one woman every 4 or every 5 had to go back to surgery. And this is a report from the National Cancer Database on over 500,000 patients. And this is a tremendous pity, because that means that, first of all, a woman has to go back to surgery. The second, we have a lower cosmetic effect, because we have to take another piece of breast out. And we delay adjuvant therapies, and we have an additional cost for our health system. So we have tried to decrease these re-excisions, understanding not all re-excisions are necessary. And this is particularly important for young women. This is again in 2014. Look here that among women below the age of 40, 1 out of 3 women had to go back for a repeat surgery. And we thought that this was unacceptable. This is more unacceptable because what has happened in the last 2 or 3 decades is that local relapses have decreased, and have decreased tremendously. So that now for some sort of highly expressed estrogen receptor tumors, the chances of local relapse is 1.7% in the first 5 years. So what has happened 3 years ago, there has been an international consensus conference among surgeons, oncologists, radiation therapists, and they have all agreed that we can use a very small margin of excision. We don't need to take half a centimeter or 1 centimeter of free margin, but we need maybe 1 millimeter, 2 millimeters. That's good enough, because this is associated with lower rates of ipsilateral breast failure. And this has impacted tremendously over our practice all around the world. And this is a study which has recently shown a 35% decrease of reduction of re-excision after primary surgery. The fourth thing is that not all tumors have the same risk of local regional relapse, and surgeons understand this very, very well. As I was telling you before, luminal A tumors in red have a very, very low chances of recurrence, so that we can minimize surgery if all tumor has been taken out with a very low chances of tumor recurring. A few minutes ago, one of the guests asked something about the lymph node management. And 15 years ago, we have changed our approach. Instead of taking out all the lymph nodes in the axilla, we have shown that one is good enough. We take out the first lymph node, so-called sentinel lymph node, And if the first lymph node is negative, all the others are eventually negative. So it's not necessary to take 15, 20, or 30 lymph nodes unnecessarily out. Things have evolved since then, and now we have proof that even if you have one positive sentinel lymph node, you can, in approximately 50% of the cases, we can do axillary conservation if you do radiation therapy and systemic therapies thereafter. And this is the results of a US trial, randomized trial over 800 people, 800 women, showing that overall survival is the same whether you take out all the lymph nodes or you don't, and that the chances of recurrence are very, very small. So that now in clinical practice, we don't take out, in all cases, all the lymph nodes in all women with one positive sentinel lymph node, but we have several options. Surgery, but also observation or primary radiation to the axilla with lower chances of lymphedema. The sixth point is about oncoplasty, because indeed we want to maintain both breasts for women with breast cancer, but we also want a very good aesthetic cosmetic effect. So this is a woman with all this picture in both breasts, like a plastic surgeon usually does if they want to do a mastoplasty. And in fact, we can use the same surgical techniques that plastic surgeons usually employ to improve the cosmetic results of the breast, to take the tumor out and have a good surgical effect. And in fact, this is one case we had a few years ago in our breast unit. The seventh improvement has been about mastectomy and immediate reconstruction. It seems a few centuries ago, but in fact it was only a few years ago that many, many surgeons around the world would take the breast out and wait for the reconstruction for 2 years or 3 years to do reconstruction. Immediate reconstruction is again, in fact something that we currently employ. In Rome, about 70% of our women below the age of 70 do undergo immediate reconstruction with an expander, so a temporary prosthesis or a definitive prosthesis. And in many, many cases, without detaching the muscle, the pectoralis muscle, to cover the prosthesis, but just to put the prosthesis under the skin. Many, many women are interested in knowing what's going on in prophylactic contralateral mastectomy. And in fact, we have a tremendous push by many, many women. Please, doctor, take the breast out or take both breasts out. And this has been tremendously discussed in the United States, less in Europe, less in Italy. But in the United States, 40% plus of women do undergo mastectomy, and half of them contralateral prophylactic mastectomy. Well, we now know that contralateral prophylactic mastectomy should be discouraged in most women without knowledge of BRCA mutation, BRCA mutation, and should be discouraged particularly for the average risk woman with unilateral breast cancer, of course for women with advanced cancer, because they have to be focused on the treatment for the primary tumor, for women with high risk of surgical complications, and in men. So let's keep in mind that we have no proof that taking 1 or 2 breasts out improves our survival. Can be chosen by a woman, can be chosen by a woman, and in our unit has to be discussed by the multidisciplinary conference before the surgeon is allowed to do the operation. Nipple-sparing mastectomy is the last improvement that we have in our armamentarium. We used to take the nipple out, and this was almost a dogma 20 years ago. Now we use this technique almost routinely in most women, and eventually the cosmetic effect is very, very good, as you can see, with a very, very low chances of local relapse in the nipple-areola complex. So this has been a tremendous improvement, because a woman can come to the even if she necessitates mastectomy, can come to the operating room with 2 breasts and get out of the operating room with 2 reconstructed breasts. The 8th improvement has been neoadjuvant chemotherapy. So a tremendous cooperation between oncologists and surgeons. Sometimes tumors are very big or so-called aggressive. And for these women, there is an advantage of doing neoadjuvant chemotherapy, so chemotherapy before surgery. Because as you can see, the tumor shrinks, it disappears in about 1/3, 1/2 of cases, and less surgery can be done with a very good cosmetic effect. Think about doing a primary surgery at the beginning would have meant to take most part of the breast out. But one other reason to use neoadjuvant chemotherapy is to sterilize the positive lymph nodes in the axilla. And this is true for about half of the cases. So if you have 1 positive lymph node in the axilla, you can do chemotherapy first, kill the cells under the axilla, take that lymph node out, and if indeed it is negative, you don't need to do the whole operation thereafter, with a tremendous advantage for the woman. The 9th point is that I would like to stress that not everything is genetic and not everything is a scientific improvement, but there is something even beyond that, and that the specialist is a prognostic factor. And this has been demonstrated in all continents, in many, many studies. Women that are treated by specialists have a better survival compared to the women treated by a general surgeon. And as I view a breast unit, I think this is the major improvement that we can offer women in 2019. And if I can show a breast unit, I have in mind 3 pictures, and I would like to share them with you. The first one is an orchestra, because all players here have to work together, and it's impossible that any of them plays his or her own game. And the results are very, very good if they all work together. Or they can scare cancer, like I think these are the All Blacks or something like that. I don't play football, but it gives the idea of what we would like to show cancer. We can be more aggressive than cancer. Or we can be a trapezist. And I like this picture because it gives the idea that you can't be 1 second behind. You have to play together because otherwise the whole game is over. What is a breast unit is difficult to explain because it involves a tremendous amount of people. It has to have, of course, a clinical director, at least 2 surgeons, at least 1 plastic surgeon, 2 radiologists, at least 1 pathologist, 1 medical oncologist, 1 radiotherapist, and then people for rehabilitation, clinical protocols, annual audit, weekly meetings, dedicated clinics, a breast nurse, a data manager, somebody expert in genetic counseling, a psycho-oncologist. They have to cooperate with screening programs, be involved in research programs, and be helped by supportive groups. So this is a tremendous work together. And this is our game. Our game is more quality, more cases, less money. And I want to show this with you because we like to sell this product in the national health system. If you do all this quality for 50 cases, it costs too much. And that's why we have to create breast units, because the cost in euro, if you want to keep quality as an independent factor, has to be units that take care of more than 300 women per year. And that's what we're trying to do in this country. And the 10th point is about accreditation and certification. We have to get breast units that are accredited in the system, in the health system, and they have to provide evidence that they are certificated following quality indicators that have to be reproducible. These are our 2018 European certification quality indicators. San Giovanni ad Dolorata Hospital has been certified by the European body by the 3rd year now. And as you can see, that's what we check 3 times a year. And if we have some critical points throughout our work, then we go back, we try to understand why, and get things working better. And this is a tremendous difference in our approach. As doctors, we are making a different pictures in our hospitals. As you can see, surgeons are the ones that they never have complications. All of the operations went well, and everything is fine. And in fact, this is not the truth. And we have learned that we can do better. And we can do better if somebody comes in our places and checks on us. And of course, I am proud to show you our certificate. That is the biggest accomplishment in my professional life. As a conclusion of all this, I have learned 5 things, and I think they are even more important than the scientific progress that we have indeed made in the last 20 years. And the first thing that I've learned is very well shown by this picture. These 2 women are, they have the same problem. they have in their pocket the diagnosis of breast cancer. So they are the same from one point of view. But there is something that make these two women different. One will go to a specialized breast center, and the other one will not. And they are not aware that their difference in survival will be 15%. And this lack of awareness is not more acceptable, and we must change our knowledge regarding this. The second point is that the team gives the final result, which is superior to the arithmetic
Sum is greater than the whole of its parts.
right. Can you say that again in English?
The whole is greater than the sum of its
Okay,
parts.
the whole is greater than the sum of the parts. Okay? And in fact, the entrance, or at the main entrance of this breast unit, we have a big picture of our team for a couple of reasons. First, because we strongly believe that this is our strength. And the second one, because we like to show our patients that maybe they know me, or maybe they know one oncologist, but they must be aware that for every single patient, all this team will take part for this single woman. The third point that I've learned is that nurses are extremely important. A lot of nurses, huh? And I want to share this with you because we are full of hospitals with doctors that do so-called follow-ups. So a woman comes to the office and says, "Doctor, do you remember me?" "Yes." "Oh, yes, yes. You operated on me 2 years ago." "Oh, yes, yes. And this is my negative mammogram." "Oh, yes, yes. This is my negative sonogram." "Oh, yes, yes. Let me touch your breast. Everything is fine. Okay, go home." And this is not good enough. This is a waste time for the woman. This is a waste time for the doctor, for the surgeon, because there are 100 problems that I have not touched with that woman. And a woman, a breast nurse, a specialized breast nurse, can do this job much better than me. The fourth point that I like to make and that I've learned is that we doctors have to learn how to talk better. I'm not sure if this is true in your countries, but certainly in Italy it is so. And this picture shows this message in a very effective way. This is a big professor. I'm sure he's a very important professor, a scientist, but you know, that woman really would like to know something about her disease, or maybe the disease of her mother. And he's a little bit disturbed because he has to go to a meeting. And this is no longer possible. The fifth and the last point, and we must have physical spaces for our breast unit. Our hospitals are made of thousands of hospital beds and very little services. We need to do the other way around. We have to have very small number of beds. Patients comes in, gets operated, next day home. We don't need 20 beds for our breast unit. Our breast unit has 4 beds. And we have operated last year almost 490 cases. 4 beds. But we do need a lot of services, and we do need a lot of physical spaces because we have a lot of needs. So we must let a woman with breast cancer know that in case of any problem, she can go there, she can call a phone number, she can send an email to the case manager to know whatever. And this is what happens every day in our breast unit. There is a volunteer that gives tea, coffee, and something else. I must confess that I was a little bit afraid at the beginning when we started this room, because I thought that putting together 10, 15 women so desperate because of cancer would have created a big desperation. And in fact, I have seen that the opposite is true. 10 desperate women create a big hope. Thank you.
Thank you. Could you bring up the screen? Perfect. Thank you so much. Okay, so we are a little bit short on time, but I think we should take some questions if the audience has any. I have one question to start with. This is actually for both of you. You both mentioned that breast cancer prevalence is really much higher in industrial nations, okay, in the richer nations. Is this lifestyle? Is this a matter of reporting? Like there's more reports of it, or is this actually a lifestyle issue that we're we're not eating well? Okay, I'm sorry, I'm talking too fast. It's too many coffees today. The breast cancer incidence are shown to be in industrialized nations, richer nations, much more prevalent. And I'm just wondering, is it a reporting issue, or is it that there's a lifestyle issue? I mean, like, why? I guess the question is, why is there higher incidences of breast cancer in the U.S. and Europe than in Asia?
I think that is both, but we are richer country eat differently.
Eat differently. Okay. Okay.
Eat too much probably. Don't walk, and so it's lifestyle and food and everything.
That's what I was afraid of.
Yeah.
Unfortunately.
We also use much more probably hormone in
In our food.
it's not conscious, in a non-conscious way, cause the food, and this is also the meat is possible to eat the meat. The problem is not the meat, it's not the cow. The problem is what the cow eats.
Right. Yeah.
And so I
Okay.
think it's a mix of.
A mixture. Okay. Other questions? We have Ama. We have Khalida. Go ahead.
Very quickly, it's a straightforward question. I come from a family where all the women have cancer. I was offered to do the test, the genetic test, but I was scared to do it, to tell you the truth. How reliable is this test?
Reliable,
Nel senso che ha a disposizione.
No, quanto è buono? Quanto è buono? Quanto è sicuro?
The test is reliable. I think it is highly reliable. The problem is in some occasion we can be sure that two sisters has the same opportunity to be muted or not. I mean, the family can be at risk. So the family history is. I test. I make the test. I test one of two sisters, one of two women, and I don't find mutation. Cause the breast cancer can occur anyway, independently. Can also be possible that I did a test to the negative, but the sister can be muted. I think this is the only one not completely reliable tool of this test. Yes.
You were saying that.
However, if I can
oh,
say
sorry.
one thing, is I would do. I'm sorry, you know,
So-
I think I would do the test if I were you. I understand to be scared. I have a similar problem in my own family. But I think it's good. And it's good because it's a win-win situation. If your family is negative, you don't think 1,000 times, you only know what to do. But if your family is positive, there are a number of actions that you can do to take care of yourself and to take care of your family. And I think you would be less scared if you would have a genetic consultation, because he or she would help you out in understanding your own risk, your advantage, potential advantages for your families. I would not suggest to do the test by yourself. This is the mistake, that you are thinking to do the test by yourself. It's like you would drive a car without having the license. You can't do that. You go to a genetic expert. He or she would engage in understanding what's going on in your family and will give you the best suggestions for you and your daughters and anybody else.
Thank you. Anna?
You said.
What others have done in your similar situation is to go through some pre-test counseling before doing their protesting. No, I was just talking about pre-test psychological counseling. In the unit, we may have
Yeah.
certain like that can prepare you to do the test. Yeah.
Okay. Yes, thank
You
you.
said countries are different. Are races different? Are there is there a higher incidence of breast cancer in some races?
I'm sorry, I don't understand, because I was looking for Could you repeat? I don't listen.
You said the incidence of breast cancer in countries is different, notably different. Is it different in races as well?
See, the races,
Blacks, whites, Asians within the.
Yes, the answer is yes. There is a higher incidence of triple negatives among Afro-Americans.
Afro-American for breast cancer anyway, yes. Much more.
And in Ghana, in particular, I'm not sure if... Huh?
She's from Ghana.
Yeah,
Okay, I'm sorry. But in Ghana, there is a higher incidence of triple negative breast cancer. Triple negatives are the ones with no expression of the receptors. Yes, estrogen, progesterone, and growth factor receptors. Are the more, in fact...
yeah. Because in Ghana study, the women are being studied for this. Probably, we don't know if it's just Ghana, but Ghana has been the first country in Africa that did this. So.
Okay. Other questions? Teresa? Do you have the...
One of the presentations, late pregnancies was listed as one of the cancer risks. And my question is, but because, say, older women need help in getting pregnant, is that why? Or it's an age
Also.
factor? Or once you have your child at a late age, there's a higher risk after the pregnancy?
There is both the situation. So late pregnancy has been associated to breast cancer risk. The pregnancy helped with hormonal therapy has been associated with breast cancer risk. So probably the two. has been also associated to less breast cancer risk, the early childbearing or like breastfeeding, but it's not a rule. But usually, yes, both.
Other questions? Yes, okay.
Oh, thank you. Yeah, it was surprising that cancer prevention, vaccination against probably HPV virus, right? Is that what you're referring to? Is supposed to prevent cancer. But from what I know, inside a vaccine, you've got aluminium, mercury, formaldehyde, polysorbate, antibiotics, which in themselves cause cancer. So, and I think that, please correct me if I'm wrong, because, you know, I'm not a cancer expert. Well, I mean, that's beside the point. But 50% of the population do have HPV virus inside them anyway. It's just that depending on the condition of the, what's the matter with the microphone? Yeah. The condition of the biological terrain at that moment depends whether that virus will present itself or mutate, you know, back into its symbiotic form. So therefore, it's not there anymore. So I really don't understand why they connect HPV with cancer. Cancer is a immune system problem, you know, so I just, can you understand, can you tell me why vaccination would be? Sorry?
No, I have a slide, I don't know. I have a slide for this. See, please, did you finish your question?
Oh, well, no, I could go on all day, but never mind. Sorry, it's just surprising.
Oh, it's very complicated. There is a lot of things inside. There is a slide I have here, I can let you. This is the HPV distribution. This is HPV breast cervical cancer incidence, are absolutely overlapping. And HPV is for sure the unique cause of cancer, of cervical cancer. And is also the cause of other cancer, for oropharynx, male cancer, and so this is sure. In which way the vaccination can help? Yes, it's true. HPV exists everywhere, but in our body exists a lot of other bacterial or viruses. Absolutely not refractory to antibiotic, but we are alive. The problem is in why our body at a certain point receive damage from this virus that is there. We probably cause many our lifestyle or disease or HIV disease. In this case, HPV can become dangerous for us and can develop. The vaccination contain probably, yes, mineral or poison, but nothing in comparison to the poison that we breathe or eat every day in everything.
When we breathe in the poisons from the air, or if we eat something that contains mercury, aluminium, what it is, we absorb like 1/400% of that substance. Whereas when you inject it into your bloodstream, you're injecting 100% of that substance. And aluminium is not excreted; it goes to the organs and to the brain, and it accumulates. This is the problem.
Yes.
Perhaps I better speak to you by yourself. Individually, because otherwise it gets too deep.
If I may, we are looking at we weigh the benefits against, the risks, and then we make a decision. Exactly, we look at the benefits. And we also looking at the toxic doses. So a lot of research before Food and Drugs Administration of any jurisdiction passed these drugs into the market for it to be used clinically. A lot of research would have gone on to assess its effectiveness and its use within the market. So indeed, it would not be passed if it would pose so much risk to the population. I'll leave it for Doctor to comment.
This is something I'd love to discuss
We have,
with
I'll
all.
take one more question, and then we're going to have to call it a day, unfortunately. Okay, May. Okay, okay.
Thank you. In my family, there is no breast cancer, but all the rest. It happens that my mother died from liver cancer. There are a lot of cancers. Should I be worried?
Depend. We have several familial cancer. It's not only breast. I spoke about breast ovarian. There is the Lynch syndrome, that is the inherited the inherited cancer for colon or gastrointestinal, in which we can also find some breast cancer or some uterus cancer, but it is a especially a colon cancer syndrome. I don't know if it's your case, or there are other very, very rare syndrome, the Li-Fraumeni, in which you can also see lymphomas, or the Cowden syndrome, in which you can see thyroid and lipomas and colon and breast. So if you have some doubt, please go to the genetic counselor. Probably not. But for inherited syndrome, it's crucial that are 2 or more generations. So you can also have 10 brothers and sisters with disease. But if you don't have before and after, or after, rarely is a syndrome, an inherited syndrome.
Thank you. Okay. One more, and then we're, yeah.
Yes, if I may, I have a question for one of our retirees who sent in an email to me, and now I can't see it. She would like to know what tests should she do to identify metastases? So she's somebody who's had breast cancer in the past. And how often should she do these tests?
This is well studied, and in fact, not much unless there is a special breast cancer type or a stage. But if you see the international recommendations regarding follow-ups, generic follow-ups for somebody who has an average type of cancer, is to be minimalist, because it doesn't seem to be very effective, and because the risk is usually not tremendously high. So that the ASCO recommendations for all radiological testing are chest X-ray, not recommended, CT scan, not recommended, blood test for tumor markers, not recommended, bone scans, tremendously not recommended. So usually, unless it is directed by the oncologist or the medical team, my suggestion is that we have to believe that we are cured once we get out of the hospital. And this is the first law. And the second one is to do regular mammograms thereafter, and everything which is directed by the her medical team.
Wonderful. That's really great. So I think our time is up, all right? And I want to thank our guests for joining us. I think I've got just a couple of take-home points, and that's the importance of taking care of ourselves. Early detection is critical to recovery. Be aggressive as the cancer. Prevention is closely linked to our lifestyle. And then breast centers. What a wonderful concept. I mean, I really feel inspired. And you know what, your fear about having 10 women who are desperate in a room, again, it goes back to the point of women supporting women and the power of the pack, which is just amazing. So thank you very much to everybody. Thank you. A special thanks to Kim for setting this up. She worked her butt off, okay? Thank you.